So last week, I met a person with FND whose doctor, upon diagnosing them, told them that they should just go to the spa. And this really set a lot off for me. I've heard many things like this before, but this might have taken the cake. And so I shared in a post today for people to share some of the just terrible things that people have said to them about their FND. And oh my gosh, it's quite devastating, to be honest. I'm going to share some of those today, and I'm going to review an article that goes step by step through what should happen for FND assessment and treatment. So I'm so excited that you're going to join me today for this topic. And if we haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist, and I am the owner and founder of Re+active Therapy and Wellness. We're in the Los Angeles area. We provide integrated care for people with really complex conditions, and we do education for other clinicians too. And so this article review is helpful whether you're a person with FND or a clinician looking for ways to better serve people with FND. But I want to start off with this. So as I mentioned just last week, by the way, for some context, I do the screening interviews with people who are looking to join our integrated program. And I met a person last week who shared that they were having functional seizures and other symptoms. They got the diagnosis of FND, and that physician said, well, you should just go to the spa. That is one I had not heard before, but I want to share. So I shared this today in a post, and oh my goodness, the things that people would say, like this is a common one. For example, was told by physicians, my daughter would just walk when she wanted to. These are things you would never say to anybody with neurologic symptoms, much less any symptoms, that they're faking it, that it's in their head, that they would do it if they wanted to. Just do yoga is a really common one that comes up. Just do yoga, just decrease your stress, just take antidepressant, try a facial, was what a general practitioner said. Did you teach yourself how to move that way was another one. Somebody else who had a really stressful job was told to just go back to work. There's many, many more. So if you go back to our posts on Instagram, you'll see what people have shared. And there is a much better way. So I want to review this article. This is a great article, by the way, for clinicians as a review of what can be done from an assessment and treatment side of FND, but also if you're a patient to bring this to your neurologist, your doctor, your therapist, any of those things. We wrote this article. So this was published last year. This is an article by our interdisciplinary team, and we wrote it after a group of neurologists, amazing movement disorder neurologists at UCLA, asked us to write this paper. They asked us because we have a fellowship program. I want to pull up the paper here. We have a fellowship program where one of our physical therapists, the movement disorder fellow, is in the clinic with the UCLA neurologists. And this fellow was bringing in lots of assessment and treatment ideas for FND. And the neurologist said, hey, every neurologist should have access to this. So let's write a paper. And Jody has asked, how can we get a clean copy of this, please? This article is available free full text. I will include it in our newsletter this week. So if you are on our newsletter, you'll get it in the newsletter. If you are not on our newsletter, comment on our post earlier, comment newsletter. We'll send you the link to get on the newsletter. Our newsletters go out on Fridays to clinicians and on Mondays to patients. So this is the paper. It was in Practical Neurology, and it's called Clinic-Based Assessment and Treatment Strategies for Functional Neurologic Disorder. And again, it's actually geared at the neurologist. This is practical neurology for the neurologist, but can be for any clinician. And again, it is a really great resource if you have FND and you want to take it to a clinician. So one of the reasons that we wrote this, not only did the UCLA movement disorder team ask us to write this, we see and hear from many patients that they were given the diagnosis, sometimes improperly, but then they were given nothing. Or they were told ridiculous things like go to the spa or get a facial or just do yoga, which are, by the way, all really great things, but that's not a treatment for a neurologic disorder. And it's very dismissive, and it's based on a lot of misunderstanding here. And so this article goes through first the clinical diagnosis of FND. And this is really important. The clinical diagnosis of FND is not just we've ruled out everything else, therefore it's FND. There are positive clinical signs. So we actually go through in the article, what are some of those positive clinical signs? What do they look like in the clinical presentation? So I'm going to share another picture here. I know it's really tiny. I'll walk through these. The clinical presentation of motor signs, sensory signs, autonomic pieces, maybe lifestyle disruptions that are occurring, as well as relevant psychosocial factors. Now, and the psychosocial is at the bottom. What I hear from a lot of people, and this is due to a lot of the myths and misunderstandings around FND, what I hear from a lot of folks is that they are automatically in that like bottom level of like, well, this is a psychological issue, you are stressed, and you need to go to a psychologist. Now, as a person who regularly sees a psychologist, I'm very pro going to a psychologist. I'm not pro as that being the only option for people who have a neurologic disorder that is much more complex than just psychology. So we actually outlined so in that first column is the clinical presentation. Here are either the motor signs, so things like the Hoover sign, hip abductor sign, tremor signs, sensory signs, the autonomic dysfunction, lifestyle pieces, as well as relevant psychosocial pieces. So that's all in the first column. That is all part of the positive diagnostic process. So that's the first piece that we talk about in this paper. What should that look like? And when people work with a neurologist or physician, could be a physiatrist, who is doing a differential diagnosis, they should have positive clinical signs, not just rule out other things. And also to be aware that you could have more than one thing. You could have FND and migraine, FND and Ehlers-Danlos syndrome, FND and POTS, for example, FND and dystonia. So you can have more than one thing. That is an important component too. So the clinical presentation is the first thing. Here's the second thing that is so often missed. So often what we hear is that people are only referred to psychology, and the physician might not even be screening any of these other systems that are involved and providing a really appropriate referral to people. So, and even doing some treatment within the session, right? So here's one of the things that makes FND difficult, I guess, in the like Western medical world, is that there's not a medication treatment. There's not a like, if they have FND, then we start this, right? Like in a person with Parkinson's, it's not super simple, but if they have Parkinson's, we have a list of medications. We have a lot of evidence surrounding those medications that can target the dysfunction in the brain. in FND, the dysfunction in the brain is connections between brain areas. There's not a medication that just changes the connections. And those connective issues are really complex and diverse and heterogeneous. So it makes it more challenging, right? Doesn't mean we can't do this in medicine, but it does make it more challenging. But in that second column, we outline some things that the person can do in a clinical exam that lead right into treatment. So externally focused movements, doing manual and cognitive dual tasks. These would be very simple things that a physician could do. They're often done in a movement disorders clinic already when a person's looking at movement disorders. So that top like dark blue includes some of that. And the top one is kind of that externally focused movement. The second is looking at tremor and what a physician might look at with entrainability and dual task and externally focused movement again. The next level is with sensation. And I want to spend a little time here on sensation because when I reached out to folks earlier this week, the sensory system was of a strong interest to people. Sensory and autonomic, but sensory kind of just barely beat out autonomic. They're both really important to screen in FND. And what I find is that they're missed. Nobody's even talking about these in the physician visit. And I think these are largely missed. And this is such an opportunity in that physician visit to actually screen these systems, even provide some suggestions on treatment and provide a really good referral to physical therapy, to occupational therapy, or speech therapy as well, right? So what can we do? So if a person is experiencing sensory changes that are consistent with FND, that the person, the medical provider, the healthcare professional can actually look at things like discrimination tests, stereognosis, graphesthesia, and actually try a couple of things. So for example, they could just increase proprioceptive input around that area. That could be adding a simple weight. That could be doing something as simple as an ACE wrap. These are things that literally take 1 or 2 minutes to do and to trial and to just see, does this change with a shift in sensory input? Does the symptom change? This is where we would advocate, and we even made for our neurology clinic a little kit of having a weighted item, of having an ACE wrap handy, and then being able to educate the person too that a component of their functional neurologic disorder might be related to the sensory system. Now, that is one very, very simple way to look at this. The sensory system is it's quite vast. This is not addressing things like interoception. This is not looking at a person's sensory profile and understanding their sensory regulation throughout the day. I actually don't think that those are areas that a physician's going to explore, but they can educate a person that these are things that have been found to be associated with FND symptoms and provide some resources, particularly referral to OT or PT to address those exact pieces. And I would say when it comes to things like functional seizures, every single person with functional seizures should be educated about their sensory system, their autonomic nervous system, lifestyle factors, psychosocial factors that might contribute to a functional seizure, and be provided really appropriate referrals. That might include psychology, but it should absolutely include occupational therapy, for example, and physical therapy to help manage that. I saw a question come up, so I wanted to take a pause here. By the way, folks submitted great questions all week that I'm going to answer today. The question was, I've heard some positive signs don't always apply to some people with a subset of dystonia and FND. Is that correct? Great point. And I'm going to bring up another table where we talk about different subtypes, but absolutely. So just like any other neurologic disorder, functional neurologic disorder has many different types, and the positive clinical signs like the Hoover sign or hip abductor sign, those are appropriate for weakness, not dystonia. The entrainment test is appropriate for tremor, but not weakness, right? And overall, what we're looking for from a positive diagnostic sign for things like functional dystonia, for example, is it variable? Do the muscles that contract involuntarily, are they variable? And does it shift with attention to the symptom? And those things will apply across many subtypes of FND. But again, like functional seizures also have positive clinical signs. So you're right, and thank you for that question and comment. There are, yes, a lot of different presentations, and yes, a lot of different clinical signs. Okay, so we were on sensory. This is where, again, we would really advocate for a healthcare professional to screen the sensory system and to refer. And in fact, in this graph, so I'm kind of in that second column there, the treatment that you could provide in the physician clinic. The next column is the healthcare referral, like who can you refer to? And the third is actually, what are you going to recommend? So these are the evidence-based recommendations. Very, very simple, right? Like you could have a whole book on these. This is like 2 sentences. So for example, it says sensory, graded exposure, localization of touch, graphesthesia, using the sensory profile, testing for sensory sensitivities and needs, so that the physician can know I'm referring you to OT for these things, right? And gosh, that would be so much better than telling somebody to go to the spa. Holy cow. The next, so that was sensory. The next is autonomic dysfunction. And again, the physician can listen for clues about this and what the person is saying, right? So they're overheated a lot. They're lightheaded and dizzy when they stand up. They feel like their heart is racing. They have constipation or urinary retention. These are just some examples of autonomic signs. The physician can screen for these, right? So we advocate for screening with an active stand test, looking at heart rate variability, and the physician can easily add in things like, let's look at these symptoms with an extended exhale. Let's refer you to cardiology for workup, for POTS. Let's try abdominal compression and see how that makes you feel, right? So very, very simple things, even lifestyle things like increasing salt or water intake could be very, very helpful for a person in the moment. And again, they should be referred, right? So they should be referred for physical therapy, occupational therapy to understand the autonomic dysfunction or dysregulation. And then again, in that last column, it says, hey, therapists, this is what we can do. We could do a graded exercise program or activity program. We could work on nervous system regulation or grounding techniques or pacing, right? So again, I could do a whole class on autonomic nervous system training for physical and occupational therapists. We put it into like 2 lines, but at least the physician would know, hey, I'm referring you to OT and PT for these things. I saw another question, so I'm going to pause here. All doctors find it impossible to identify if it's FND. I'm not sure I understand DID switches, Tourette's, or a symptom of ME. Are there tests to help them differentiate? I've seen a full spectrum of specialists in the area. Thank you for this comment. So that was not the full scope of the paper that we wrote here, but yes, there are things to help differentiate many of those things that can look similar, as you're saying, like functional tics versus Tourette's. There is actually a whole paper on this, and that person should be going to a movement disorder specialist to help differentiate those things, because part of it, this is neurology as a whole. When we think about making that diagnosis, yes, there are clinical tests and exams, and maybe there's blood work, maybe there's imaging, things like that, although those things are not positive in FND or Tourette's for that matter. But the clinical exam, the subjective history, the timeline of symptoms are really, really important. So yes, there are some key clinical exams in watching that person clinically and doing some of the testing that would be positive in FND and not positive in Tourette's, for example. They'd be positive in FND and not positive in myalgic encephalitis. So absolutely, and some of those key pieces are within the variability and the attentional component. Now, I want to emphasize people can have both. And it actually really makes sense that people have more than one thing, because FND can very frequently coexist with other neurologic disorders. And that's because of the brain network changes that occur in other neurologic disorders, the attentional focus that shifts in other neurologic disorders. And it makes sense that you would have both. And what I would say, a very skilled clinician or therapist would say, okay, you've got functional neurologic disorder, you have a hypermobility spectrum disorder, you have POTS, you have myalgic encephalitis, and then maybe you also have fibromyalgia and irritable bowel syndrome. We could go on and on. Most of the folks that we see have many diagnoses. The important piece, and this is why we present this here, is what are some of the overlapping pieces that the person can most benefit from treatment for. Overlapping pieces of a lot of those are autonomic and sensory and lifestyle components. And that person, no matter the diagnoses or the many diagnoses that are overlapping, they would benefit from a referral to OT and PT for treatment. So we do talk about screening for some of these common coexisting conditions. Somebody also saying narcolepsy was also mentioned as a possibility. Another condition that could coexist with these, and again, there's very clear testing for this as well. Okay, so we talked sensory, we talked autonomic. The next one is a lifestyle piece. This is where we would look at what's happening for the person with their sleep, what's happening with their energy and fatigue through the day. What's their pain like? Are they able to participate in their activities of daily living or not? And I will say there's not necessarily that the person is going to provide treatment right in that assessment. I'm talking about a physician visit, but they're going to provide really good referrals. A referral might be to sleep medicine, but heck, a referral should be to occupational therapy, especially one that might specialize in sleep. That's all of our occupational therapists, and it's a game changer for people to be able to shift your sleep function because of what it does for the brain. Also, this is a really good referral for clinical and rehab psychology. Absolutely. And then finally, in that last piece, if the person's having cognitive symptoms, if they have a relevant psychosocial history, they should get psychosocial support. And I will say the majority of folks that we see with FND have had a terrible and traumatizing time in the medical system, that even just that deserves support and validation. So there might be screens that the person does to screen for this for a person, not just asking them, are you stressed? That's not very helpful, because honestly, in the world that we're living in, we're all very stressed. And also really giving good referrals to clinicians that really understand FND. Now, I add on here speech therapy, right? So if some of those symptoms include cognition, speech as well, language issues, they should be referred to speech therapy. And hopefully a speech therapist that understands FND as well. And there is really good evidence and support for working with psychology, neuropsychology, as well, that improves the person's psychosocial status and their cognition. This helps things like brain fog. It helps with anxiety and depression. It helps with their relationships and how other people understand their FND. There's so much benefit of that. So I don't want to ignore that, but number one, just asking, are you stressed? And then just saying, go to psychology is not helpful. We need a list of good psychologists. Let's start there, right? That understand FND, for example. And we really want, and that the person deserves to have the physician really talk about, how is this even related to my symptoms, right? They deserve an explanation, because stress does not equal FND. It's so much more complex than that. So I had mentioned this after one of the questions about dystonia. This was one other key component of our paper, was we created a table that was more symptom specific. So you can see on the left, it's the symptom, the type of symptom the person might have with their FND, the screens to perform, and then again, we could write a whole book. These are like bullet points of treatment strategies, right? So with functional dystonia, we might do sensory testing, we might look at the influence of attention, and then here are some treatment strategies. Literally, I would say, like physicians, you could give people this article. You could share this table, and I know how it is to be a PT and kind of go, okay, I know you need something. I don't know. I don't have the skills to provide that something. Here are some resources for you, right? So this is a resource to give folks. So for example, if sensory testing is impaired in that person with functional dystonia, they might suggest increasing proprioceptive input to that area. And then we have suggestions for functional tremor, functional weakness, gait disturbances, and then again, the autonomic dysfunction. This is so common as comorbid, coexisting with FND. It deserved a line of its own. It includes the active stand test in there for screening. And then, the physician can give education on exercise progression. I advocate for physicians to have bubbles in the office, but let's try some externally focused breathing. Let's do some grounding to the environment in the moment. Let's have some education on compression wear, water intake, salt, for example, all of those pieces, even on counter maneuvers. So this would, save so many people to have this screened, identified, even initiated treatment or referral for treatment right away. So that gives a lot of resources to physicians. Now, I know that in our current healthcare system, in our current healthcare climate, that time is limited. That is why we made this so brief and so concise, that this is certainly not a all-encompassing treatment guide for FND, but it gives very brief things that can be done in a physician's office to get somebody started on the right foot, to stop being told to just do yoga or just go to the spa or just have a facial, but to give real evidence-based treatment recommendations. I'm getting a question, is this paper publicly available? Absolutely it is. I will put it in our newsletter, but again, it's called Clinic-Based Assessment and Treatment Strategies for Functional Neurologic Disorder, written by our team just last year, and it's available in Practical Neurology. Now, I want to get to your questions, for which there were really lovely questions sent to me this week. So let me just pull those up. And this one, I have a patient with only sensory symptoms, numbness. I don't know what to do. Great question. And again, the sensory system kind of came up as a hot topic for folks, whether you're clinicians or a patient. And I think this is an area that is, as a clinician, I didn't get much training in. So this is an area I've dove deep over the last 10 years. So if somebody has only sensory symptoms, I want to test out those things. It sounds like they have numbness, and I'd really want to understand what is the nature of that. I'd want to test out 2-point discrimination, stereognosis, graphesthesia, minimally to understand that. I might also look at vibration. So number one is assessment of it. If there are sensory symptoms, we need to assess the sensory system. Now, those were all tactile type things, and we know that the sensory system integrates with all of the other systems, right? So if they're experiencing numbness, I actually want to understand what are they experiencing in the other systems. So this is where doing a more thorough and deep dive into the sensory system, this might include their sensory profile. This might include testing their interoception and looking at a self-report measure like the MAIA. This might include looking at their sensitivities to other sensations. So I like to look at vision, vestibular, proprioceptive, smell, taste, in addition to the touch perceptions, to see how they are integrated. Another thing that I would say with numbness is sometimes the brain and those connections in the brain will actually produce a numbness as a very protective response. So I would want to understand there were injuries, pain that preceded this, and I would kind of work backwards from that. There might be that we need to create an environment and within the body, a sense of safety in order to proceed with treatment. And then finally, I would say we want to think about how the sensory system overlaps with other systems, and could we enhance sensation through a person's automatic movements and motor control, autonomic nervous system regulation, maybe some lifestyle pieces. So sleep is a really big one that I think about as well as psychosocial. So some folks experience really profound numbness from a disassociated state, and that's not under their control. And we would want to think about things that we can do for that person to reconnect to their body in a safe way. Really great question. let's see. This person is looking to get a proper training to program to get yourself feeling better. Doctors say to try to ignore it all. So maybe another unhelpful piece of advice is just to ignore it all. And perhaps that comes from a myth or misconception that you're making it up or overly attentive to it. And first of all, when folks have involuntary neurologic symptoms, they're very hard to ignore. And of course, your attention is going to go to them. So I want to say that first. So just quote, ignoring it all is not really helpful. And in fact, trying to ignore or trying to suppress symptoms can backfire and make it worse, because it induces a sense of fear around that symptom. That fear can amplify and excite the nervous system and can actually make symptoms worse. So not super helpful information or advice for the person with FND. But I want to say maybe there's a sliver of truth in that, and that we know and understand now with some of the brain imaging in FND that those attentional networks, the default mode network, might be doing too much. So it might be turned on too high and overly attentive and aware of the body. This is not your fault. You're not consciously doing this. This is the brain. This area got turned on. And we want to find ways to regulate that a little better. We need that part of the brain. We need the default mode network, but we don't need it on 24/7 and at a very high level. And so just ignoring things don't really turn it off. It's actually engaging in really salient and purposeful activities that help the balance in those systems. So what I would take from like, instead of just ignore it, I would say, no, we actually need to acknowledge it. Symptoms. We don't want to keep building fear of those symptoms. What we do want to do is engage in very purposeful and meaningful activities to shift the brain balance, so to speak. Somebody is asking about the slide deck. So I don't have any slides. I'm just sharing pictures as I shared this article. I'm just sharing pictures from the article. So if you download the article, you'll have everything I shared today. Okay, great question. Next question. Helping my patients carry over strategies we practice in the clinic to home. I hear this question a lot from my fellow clinicians, and I just adore you. I adore that you care so much about this. And I also recognize this is really challenging, right? And it's challenging for all of us as clinicians to really find ways that what we do in the clinic becomes meaningful at home and can be carried over. And so my number one piece of advice for this is that you really collaborate, like heavily collaborate. And what I mean is when you're working with that person in front of you, they are driving the bus and you are along for the ride to give them a little guide. And when that person can take control, they are designing a program for themselves at home that becomes meaningful to them, purposeful, becomes habitual, and something that they can really, really do. And I know that's not an easy thing, but that has definitely I've been found to be most helpful. Another question from the same clinician: helping my patients find a multidisciplinary team. Scheduling and access to providers are challenging. 100%. It's really challenging. And part of our mission is to keep educating clinicians and keep helping them build their teams. Right now, for example, we are doing a boot camp course for Hartford Healthcare, so like Connecticut, you got a whole group of people that have been learning about FND, a whole team of people. And even then, in a large healthcare system, it can be really hard for people to access the team. I just want to like put it out there that this is a challenge in our healthcare system. This is exactly why Re+active has developed to have an integrated healthcare team, because it was so hard to find. But we're only one group. Well, we're a group of 30, so we're pretty big, but we're in California. Not everybody has access to that. It is one of the reasons we created our online Functional Neurologic Disorders membership for people, because they can have an access to a community with our expert team. It's not one-on-one medical care by any means, but it's a step in being seen and heard by a multidisciplinary team. So those are some of the other resources out there for you. Okay, another question here. This is from another PT. Where to begin? Because sometimes it's everything. So absolutely. And I'm just going to come back to this image from the article that I reviewed here. This is a little version of our pie chart, right? So we've got motor control, we've got sensory, autonomic, lifestyle, physical impairments, and psychosocial. Where the reason we created this and our pie chart is because there were also often so many things, it was hard to know where to begin. This is like coming from me and our team. Like we struggled with this. And so we created that pie chart. I start with the person in front of me. What are they telling me is their most important, biggest symptom, biggest contributor to symptoms? So I start with the person in front of me, and I start with the biggest piece of the pie. And then I layer on other things, all directed to that person's goal, right? So for example, one of the people that I met just yesterday had a goal to drive and had really an enormous sensory contributing factors to their symptoms. So we're going to assess the sensory system. We're going to start treating in that realm, gearing towards a goal of driving, right? So that would include visual motion. It would include their reaction time for things, all of those pieces. So goal-oriented and start with the biggest piece of the pie. Next question here was consistency and progress due to inaffordability and insufficient clinical knowledge. This person says across Australia. Well, I will tell you, we currently have some folk. I know Australia is really big, but this particular physio is in Perth. I believe I have that correct, but we have folks in our Brain Bites community, which is a community for clinicians who are really committed to complex care, and they're doing learning and mentoring with us all year round. So we have at least one person in Australia. This is really part of our mission. It's actually why when we did our FND weekend course, this month, we did it online so we can train other folks who maybe can't come out to California for a course. We did it online, we recorded it. Like, this is our mission, to keep spreading the word and improving access to care. The other thing I would say for folks that are international or out of state, our FND membership is incredible and provides access to groups and education that really provides a high level of information for people. Okay, another question here was fear with walking and heights, I believe is what this person is saying. So fear, first of all, fear is really common, and it's not surprising, right? So if you've had involuntary movements, functional seizures, you've had ups and downs of symptoms, it would be really normal to experience some fear. around those things because you don't know when they're coming. In fact, it'd be weird if you didn't experience fear around that, right? So number one, it's normal and it actually makes sense that you'd be experiencing fear. A lot of folks that I talk to also then find, but this fear is getting in my way. I've lost my confidence with these activities. I don't know. I'm scared to try new things, right? And they recognize it as a barrier, which again, absolute kudos to you for recognizing and having that insight that fear is paralyzing you. Fear shifts our nervous system too. Fear can lead us to shut down. Fear can lead us to be really hyper or like in a high zone, a high dysregulation. And yes, there are lots of things that we can do for that. And again, this kind of comes back to the pie chart. Some of those pieces might be sensory, they might be autonomic. They're bringing a sense of safety to ourselves and the environment around us. And some of those are lifestyle, some are psychosocial. There's a lot of pieces that we might incorporate to really help somebody move forward in the face of fear. And I think that's something actually that rehab professionals do really well. They're really a really beautiful job. Fear is really common in all neurologic disorders. This next question was staying motivated when progress is steady but still so slow. Oh, I just want to acknowledge, yes, that is so real. And, I think about my folks who might have FND and POTS, maybe ME/CFS, and we actually need to move very low intensity over a long period of time. It's very slow. And it's a major practice in patients. And here's what I'll tell you. It pays off. Stay the course. It absolutely pays off. Little tiny wins, right? 30 seconds better, 1 minute better. Those are ways to stay motivated. It's celebrating those teeny tiny moments, even if it's up and down, still celebrating any little bit forward will help keep you motivated. Really great question. And then I see some other questions coming in here. So I'm going to do this other one that was sent today. Strategies, and then I'll get to these questions, strategies to reduce sensory overload when you go outside to shops, errands, driving, etc. What a good question, because I feel like this is a very common complaint for people, and we do this a lot in therapy, and it's very person specific. So I think, like, this goes without saying, the stuff that I'm sharing today, this doesn't fit for everybody. This isn't medical advice. I don't know what's actually happening in this person's nervous system. So I'm going to speak in real generalities here. And by the way, I think I'm going to share this with another question here or comment from somebody here live. This person is saying, I'm awful with open spaces. I need help overcoming open spaces. Does anyone else have open space problems? It's so sensory based. Very, very. So first of all, you can see you're not alone. Somebody asked similar questions, whether it's open space or a crowded space or outside, or driving. You are right that there are many sensory components to that task. And this is very specific to your brain and body. What might you need? So as a clinician, we would be doing some sensory assessments. We'd be looking at the sensory profile. We'd be looking at your sensory preferences and sensitivities and working to integrate other sensory systems with those that are required in other spaces. One of the things that is really common in open spaces or busy spaces or stores or driving, it's heavily visually reliant, right? And if our visual system is taking in a whole lot of information, but our other systems are not. So our vestibular system maybe is kind of downregulated. Our sensory system is downregulated, but the visual system, it's highly attuned. This is also an autonomic feature. So if that's really high and the others are low, it's so hard to be in an open space or a busy space. So you really need to look at balancing those systems. That's why just working on visual things is not helpful, but the integration of those with other systems is really helpful. So a thorough assessment of that can lead into treatment. What a great comment and a great question. I was just scrolling here and I think we've got all of them. So thank you so very much for coming live or watching the recording of this. We can do so much better as healthcare professionals, and we must do better. Giving somebody a diagnosis of FND and then just telling them to go to the spa is not helping anyone. This article, so I'm just going to share it here one more time, provides really clear clinic-based assessment and treatment strategies for people, for physicians, for any healthcare professional. Is this the whole textbook? No, but it's a simple way to start. That's why we wrote this paper. So this is the start of all of us getting better and doing better for people with FND. Thank you so much for coming. And I'm going to remind you that next week, it's next Tuesday, October 21st, we are doing a brand new free workshop for people with FND. And you can comment on any of our posts, FND, and we send you the link for that workshop. We're going to do it live. We're going to send a recording after. But if you come live, we are actually doing a special focus on the sensory system, and we've created a guide, a sensory toolkit guide for you that is free when you show up live for our FND workshop. So if you have FND, if you know somebody with FND, if your patients have FND, please send them to our workshop. I'm so excited for this as a way to continue to provide resources for people with FND who maybe don't have access to care too. So I hope to see you there live, and I hope you have a great rest of your week. Thanks so much for tuning in.